Good morning, viewers. Now, today's topic of our discussion is brachytherapy in cancer cervix. This entire lecture is purely dedicated to our postgraduate students of radiotherapy or oblique clinical oncology. They should understand a little bit about the history of brachytherapy in cancer cervix and the steps which we follow for a cancer cervix should be very very clear to them. And so in view of that, the cancer cervix brachytherapy is a very very important chapter. One should always remember uh, few points regarding the brachytherapy. The behind the concept of a brachytherapy, we know the radiation tolerance dose of a cervix and vagina is almost 90 gray, very high, and even the uterus is further high, is almost 100 gray. This fact is fully exploited when a brachytherapy is combined with external beam radiotherapy. What we give in the external beam radiotherapy is dose up to 50 gray we delivered, but we cannot give full dose to by external beam radiotherapy because of a rectal tolerance dose is 60 gray and urinary bladder tolerance dose is almost 65 gray. Uh, Tolerance dose make the process difficult to deliver the full dose of external beam radiotherapy alone. So that the combination of external beam radiotherapy and brachytherapy, we can achieve the giving the full dose to the carcinoma cervix, that is almost 80 to 85 gray to the point A we can deliver. So about the history of carcinoma cervix, the first time the radium was used as a brachytherapy source for carcinoma cervix, and in between the period of 1910 to 1950, the three systems were developed for the treatment of carcinoma cervix. The first was Stockholm, the second Paris, Manchester system. The Stockholm was discovered in 1914. Rigord discovered the Paris system 1926, and a further after the 10 to 12 years, the Manchester system developed by the Todd 1938. So, in all this Stockholm, Paris, and Manchester, the source of brachytherapy was radium. One thing one should remember. Uh, Second, and further important point, in all the system, Stockholm, Paris, Manchester, where preloaded system was there for delivering of a brachytherapy. And then the all the system like Stockholm, Paris, the point A definition and a point B definition was not clarified, but in the Manchester system, point A and point B system was clarified. And then the most advanced was of selectron system, that is came into the light in the 1970s, where we used the Fletcher and Shoot applicator. The source of radioactive element was cesium, and it was afterloaded. That's a divide that can avoid the radiation exposure to the medical and paramedical person, and this was the LDR type of radiotherapy. So there is some overlapping of a slide, so please bear with me. There is nothing called next generation sequencing in the concept of CA cervix brachytherapy. By EBRT, we treat whole pelvis and a parametrium. So if somebody asks you by the external beam radiotherapy, what you primarily treat? We primarily treat the pelvic lymph node, parametrium, and including the cervix. But by brachytherapy, we primarily treat the upper one third of the vagina and cervix and as well as the medial parametrium. The indication of brachytherapy in carcinoma cervix, uh, in early stage, stage 1A, you can deliver 60 to 670 gray by ICRT alone. Patient with carcinoma in C2 cervix. With a strong medical contraindication of a surgery, we can deliver the ICRT 45 gray alone to point A. When we are telling this 60 to 70 45 gray, that is the LDR treatment of LDR method. Patient having a multifocal carcinoma in C2, including the cervix and vagina, the we can go 45 gray alone to point A. And in the routine carcinoma cervix stage 2 to stage 4, almost in case combination with external beam radiotherapy with brachytherapy. So definition of point A, it is first came into the light in the Manchester system by Todd and Demerit, has given the definition of point A in 1938. What was the definition? The 2 centimeter above the mucous membrane of a lateral vaginal fornix and a 2 centimeter lateral to the center of a uterine canal, called the area the point A. This area corresponds to the paracervical triangle in the medial edge of broad ligament where uterine vessel crossing the uterus. Our second definition was the point A was defined at 2 centimeter above the external os and 2 centimeter lateral to the center of a uterine canal. That was easy definition because we can easily locate the external os and then we can find out the point A. The third definition, the 2 centimeter above the distal end of the lowest source in the cervical canal and the 2 centimeter lateral to the tendon. In the figure you can see here the point A, and then the same axis 3 centimeter lateral is the point B. So the point B lies 3 centimeter on the same horizontal axis from point A. The importance of point A and point B, it has been found that the point A and point B is very vital for the dose prescription. Side by side, rectal reference point, bladder reference point and the lymphatic trapezoid point to calculate the dose received to these specific points, because these represents the entire area. Like in the point A, 85 gray represents the area that the cervix has received the 85 gray in order to completely neutralize the tumor cells. The ICRU report in 1938 recommendation was, it was observed that the point A can vary according to the deviation of uterus, because the point A definition was given initially that all the time point A light on the same area, but considering the fact the normal uterus anatomy, the anteverted antiflex, but sometimes the uterus has retroverted retroflex. So what will happen to point A? The point A will change. So ICRU came and ICRU 38 reports defined the reference volume. What was the reference volume? Reference volume described in terms of height, width and thickness of the volume enclosed in 60 gray isodose for LDR treatment in cancer cervix. The absorbed dose at the rectal reference point and the bladder reference point, lymphatic trapezoid point must be determined on the computer on the treatment planning system to avoid the extra dose to above said area. So see here the lymphatic trapezoid point and the right para and left para aortic lymph node, and then an anterior surface of L4 vertebra, a point taken and a 2 centimeter either side of this from the center, and a line taken from S1 S2 junction to the top of a pubic symphysis, the midline of this line, a 6 centimeter either side, represent the external right external and left external iliac lymph nodes. When we join these, that is called lymphatic trapezoid is formed, and then the midpoint of this trapezoid is right common external iliac node, left common iliac lymph nodes, so that you can design with this. And then a horizontal line passing from the the superior surface of head of the femur, and then a vertical line that represents the right pelvic wall, and similarly the left pelvic wall, so that in figure you can see. So how you find out the bladder reference point and the rectal reference point? You see the rectal reference point by the intra lowest point of a intrauterine source, and then line passing posteriorly from a posterior vaginal wall to 0.5 centimeter beyond is the rectal reference point. And similarly the bladder reference point, after putting the bladder a 7 ml dye and then a center of a balloon to the posterior side of that balloon is represent the bladder reference point. So these reference point, we presume the dose, like in the bladder reference point 70 gray, and then 75 gray, and the rectal reference point is 75 gray 70 gray dose is considered to be a dose in a limit. And it is not that the bladder is receiving the 70 bladder is receiving the, if a bladder reference point dose is 75 gray, that the whole bladder is receiving the 75 gray dose. Certainly not. It's a reference dose, it's a general dose. It does not predict that the bladder is received 75 gray dose. And similarly the rectal reference point. There is a technique for sorbo application in a post-op case of a cervix carcinoma. Cervix, post-op, post-RT recurrence, bulky parametrial disease. We put the sorbo application. The steps is a previous night prescription of a stool softener to the patient. Morning the part preparation, the pubical hairs are clean, and the given IV, IM painkiller and the sedation. And then we take the patient in the OT to PV examination to know the exact length of a vaginal length, and then the Foley's catheter 7 ml dye, radiopaque dye is delivered. Why 7 ml? Why not 10 ml? Because if you put more dye, the bulge of a balloon is there interiorly, and then bulge of a balloon might lead to the extra dose to the bladder, and there has to be a limit of more than 10 ml. You cannot put in the balloon, may rupture up. So you see here all the acrylic made cylinders are there of a different size, put it on the central tendon for a servo application. But you see here the central tendon, the point is facing towards more commonly on the interior side. Why not on the posterior side? I ask you a question. Why not on the posterior side? This anteriorly tilted central tendon, the tip is facing anteriorly when the patient is in supine. Reason, the difference between the rectal and bladder tolerance dose, because sigmoid colon and rectum we cannot give more than 60 gray, and the bladder you can go up to 65 gray, so that the dose is going to the little hair on the bladder is not a problem. But if dose goes more than 60 to the rectum, is causing a tenesmus and a post radiation proctitis more commonly. The steps further, according to the already measured length of the vagina, acrylic made cylinders are available in the length of size 3.5 centimeter, medium size 3 centimeter, and then the smallest size is 2.5 centimeters. So now the cylinders of a required number along with the applicator mm, condom and a jelly over it applied and introduced in the vaginal cavity. Anterior and posterior vaginal packing is very finely done, as much as packing is very good to avoid the rectum from the anabladder as much as away from the area of interest. Now the patient taken to the X-ray room and a dummy source introduced, an applicator, and an X-ray is taken in AP and lateral view in order to see the position of applicator. Dose calculation is upper two-thirds of the vaginal wall to be irradiated, and a dose calculation is done at 1 centimeter depth from the vaginal mucosa.